There we go. All right. Okay. So thank you and welcome everyone for joining today's webinar. My name is Dr. Sofia Wenzler. I'm a licensed clinical psychologist and also the clinical lead here at StopOCD. StopOCD is a therapist-assisted online program that can help you cope with intrusive thoughts and compulsive behaviors and is basically bringing this webinar to you. Today, we're going to do a Q&A. I'm going to go through a lot of commonly asked questions that we generally get here at Helping Minds at Stop OCD, and also some questions that were submitted by people who were planning to attend. But also, if you have a question while I'm talking or afterwards, I always try to get to all of them. So feel free to ask any and all question that might come up. Okay. So I guess without further ado, let's just jump into it. So the first question we want to look at is, can OCD manifest differently in children versus adults? So that's a very good question. And there is some differences in symptoms and obviously with the developmental level between children and adults. And I'm also going to talk a little bit about teens because those are really different stages in life, childhood, teenage years, and adulthood. But I think one idea that I mentioned quite a lot, and those of you who've been to a webinar of mine before will know that, is that OCD is a bully. OCD kind of looks at a person. If OCD was a character, it would look at a person, think about, okay, where are that person's vulnerabilities? Where are the weak spots? And this is where they're gonna, try to jump in and try to take control of your life. And those weak spots obviously can differ in different periods of life. For example, if we look at teenagers, right, they're at a very sensitive stage in life. They have to cope with all kinds of changes in their bodies, uh, exploring their own and getting to know their own sexuality and own sexual identity. And so, for example, in the teenage years, what you see a lot in terms of OCD is that you have OCD around sexual topics or about sexual identity OCD. And that's because this is such a sensitive topic for teens at this time of life. Or, for example, if you have a young mother who just had a child, then OCD will jump on that and send intrusive thoughts about possibly hurting the child when this is the most precious thing to her, right? So this is something I would also always consider, that OCD can change its shape based on what stage you are in life and what's important to you in that stage. That being said, there's some more concrete differences between children and adults. So whereas with adults, we sometimes see very abstract mental rituals, things that we do in our minds to neutralize the intrusive thoughts. With children, that's less common. So you have more concrete rituals, a lot of counting, ordering, tapping on things, just right rituals. We do also have abstract ideas of harm OCD. Also, we see that in children, but oftentimes the rituals are not as abstract as within adults. And also, you have less insight. So one characteristic of OCD, of the intrusive thoughts, is oftentimes that we understand that to some degree those thoughts might be irrational, exaggerated, not 100% based in reality. And we call this ego dystonic. We know the thoughts are ego dystonic. They don't necessarily are in line with what we truly believe and in line with our values. So we are able as adults to create a little bit of distance between us and the intrusive thoughts. So that is harder for kids to understand, right? That there are some thoughts they might take more seriously and some thoughts they might take less seriously in their lives. And a really good example that I always think about is um, a patient that I had. I think she was about 11, a girl who had intrusive thoughts of harm, OCD, of harming herself or her parents. And she was clearly suffering from those thoughts, but she had a hard time distancing herself from those thoughts because she said, well, I know that my brain is sending me those thoughts, and my brain is supposed to be the smartest part of me. So my brain is always right. So why wouldn't I believe the thoughts, that my brain is sending to me? And I thought she described it so well that the reason why for children sometimes it's hard to kind of create that distance. And we worked on that, and then it got better. Um, or in teens, you just have a lot of stressful events through puberty, through challenges at school. Those can be very triggering for OCD, can exacerbate symptoms. Sometimes something that a lot of the symptoms that you find in teens may be similar to adults, but what you find specifically in the teenage years is also a lot of shame, a lot of hiding, a lot of problems kind of opening up regarding the symptoms, either because they are ashamed or because their brain is not developed yet enough to understand, okay, this is something I have to treat. It's not just going to go away in the long run. It could have very negative consequences. So yeah, in short, OCD can manifest differently in children, teens, and adults, but there's always some core that will remain the same. All right. Another question. Is OCD genetic, environmental, or both? That is also something that a question that I get a lot, not only when it comes to OCD, but I think generally when it comes to psychological problems. Specifically, when we look at OCD, where we do have a lot of research, we see that there is actually a very significant genetic component. We know that from twin studies. Twin studies are a very important source for understanding whether a condition is caused by genes or by the environment. And I would never really, take those numbers for one-on-one because there's a lot of methodological um, differences sometimes between studies. It's a little bit more complicated, but as a general direction, one could say that about 40% of the variance that we see in OCD can be explained by genes, which is quite a lot. And we also see possibly caused by genes that there are really neurological, biological manifestations of OCD patients as compared to patients who don't have OCD. So it's not just something, that's in your head metaphorically. It really is in your head, also biologically, neurologically. So we see that certain structures, brain structures, might be bigger or smaller in OCD patients as compared to people who don't have OCD. We see differences in functioning, just differences in the way your neurons fire that we can really measure, and that might be related to those genetic biological differences. However, the influence of environment might be even stronger. So there's evidence that it might be even around 50% of variance explained by such things as upbringing, parents, experiences throughout life. So the short answer would be it's a mix. It's genetics and the environment. And to be perfectly honest, as a psychologist who has been practicing and learning and studying psychology for quite a while, I've never ever had a different answer to this question when it comes to psychological issues. It's always both. It's always a mix of both. You can find conditions where maybe genetics play a bigger role or a smaller role, but psychological problems can not be explained by one factor. It's always several factors. It's usually genetic factors, environmental factors, and then acute triggers, like things that if you already maybe have the genetic predisposition or a lot of um, um, environmental factors that might predispose you to develop OCD, and then you have this one stressful life event, and that leads to the breakout. That is usually the mix that we see. Oh, yeah, a very interesting question. Are certain personality types more prone to OCD than others? And that brings me to the topic of personality in and of itself, which is obviously a term that all of you have a concept of what it is when you hear it. But interestingly, lately or in the last years, I see a lot of personality theories that are just like making their rounds in social media that I hadn't even known about when I was studying those things at university. So it's like, first of all, there's different theories of how you define personality or what dimensions personality can have. There's one that I see a lot. It's called the Myers-Briggs Type Indicator, MBTI, where like each personality type consists, I think, out of 4 letters. And then I see people on social media saying, yeah, I'm like an EFDY or whatever, as if this now is something that everyone should know what it means. Or then we see like things like saying I'm type A or I'm type B, where A means to be like a more driven, um, hustling, maybe also uptight person, whereas B is more laid back and relaxed. I just want you to know that like why this is super interesting, and I love taking personality tests and just finding myself in all of those categories. Those are not valid personality theories. That is not something that has been tested by research where we know, okay, those dimensions exist and this theory makes sense. So, to answer the question of whether there's personality types that are more prone to OCD, I'm going to use a personality theory that is actually based on a lot of research where we know it's reliable and valid, and that would be the big five personality traits. Okay, so it means that you can kind of define a person's personality based on 5 different dimensions. Those dimensions abbreviate to OCEAN. It means openness, how open a person is to new ideas and experiences. Conscientiousness, how goal-directed, persistent, and organized a person is. Extroversion, how much a person is energized by the outside world. So obviously the opposite to that would be introversion. And it doesn't mean that one person is just closed off and not interacting with others. It really means how much are you energized by social interaction, or in terms of introversion, how much do social interactions take away from your energy. Then we have agreeableness, how much a person puts others' interests and needs ahead of their own. And neuroticism, how sensitive a person is to stress and negative emotional triggers. So usually when we try to find out what personality traits might be connected to certain psychological symptoms or disorders, then we use this theory, right? And from a meta-analysis from 2024, so meaning a body of research that, like a research paper that analyzed the whole body of research, like a lot of studies on one topic. Um, from this meta-analysis, we basically know that OCD is associated with higher scores for neuroticism and lower scores for extroversion and agreeableness. And before I tell you what that means, I just want to check, because I did get a few questions in the Q&A. Just want to check that that's nothing to do with my sound quality or anything. Okay, no, I see those are excellent questions that we're gonna get into later in after I finish. I'm gonna answer all of those questions, and thank you for already posting them, and please ask more questions if they come up. So for OCD, we're talking about higher scores for neuroticism and lower scores for extroversion and agreeableness. And that might mean, for example, if you want to put that in more concrete terms, so a personality profile for someone who might be prone to develop OCD. In terms of high neuroticism, that might be that it's a person who has a tendency towards worrying, rumination, and experiencing anxiety, someone who's very sensitive towards threats, has a hard time making mistakes or coping with uncertainty, and someone who generally perceives their own inner world, negative emotions as overwhelming. In terms of lower scores in extroversion, this person might be less socially engaged, might not feel that social interactions give them any energy or positive emotions, and might also be more likely to cope inwardly, meaning if they have a problem, they might be more prone to ruminate about it rather than seeking support or distraction or talking about their problems outwardly. And finally, lower scores in agreeableness might be that this person might be more stubborn, critical, less flexible in their thinking, and might be someone who wants that other people insist on their rules in terms of in contrast to adjusting themselves to other people's needs or rules or ideas. Yeah, so that might be like a stereotypical personality of someone who might develop OCD. How do I know if my intrusive thoughts mean I'm dangerous or if they're just OCD? That is that is a dilemma and a question that comes up in combination with OCD or in therapy so many times. That's one of the most important questions, right? Because OCD is all about how we relate to our thoughts and how much value or weight we give them. And the basic idea that I discuss with my patients when this question comes up is that we as humans, sometimes consciously, sometimes subconsciously, have thousands of thoughts every day. And there's actually a lot of them that we don't take seriously, a lot of them that we don't assign meaning to, that we don't even pay attention to, that just passes by like like a like a fly or whatever. Um, like cars when we're on a highway. Um, and sometimes we even notice, well, this was a weird thought. Like, where did this come from? And we laugh it off and we go on, right? The same is not true with intrusive thoughts. Although we sometimes know that those thoughts are exaggerated or irrational, we have a really hard time going on to the next thought. We pause, we get stuck with those thoughts, and that's because they're scary. Because, as I mentioned with the bully, they meet us in our most vulnerable places. And then we lose this distance of like analyzing and thinking, okay, this is just a thought. And we get kind of entangled with the thought. And we call that cognitive fusion. It means we treat a thought as if it were true rather than just a mental event that happens and passes. So when a person says, can it be that my intrusive thoughts mean that I am dangerous? Then it means that they are in a fusion with this thought. And we call this a personality thought fusion or thought personality fusion, meaning I'm assuming that my thoughts say something about my personality. And if that thing would be I might be dangerous, then we're most likely talking about harm OCD thoughts, right? And so the assumption is that if I imagine hurting myself or another person in my intrusive thoughts, then that might mean that I'm dangerous, um, consciously or subconsciously. And this is the way I give meaning to this thought. But although sometimes the thoughts do have some kind of meaning, it's not in the way that we think. As long as you experience this thought, this harm OCD thought, and are distressed by the thought, it means that this thought is not in line with your values, and it means that you're not dangerous for having this thought. It might say something else about you. It might say something about your values. It might say something about why this is the weak spot that OCD, the bully, chose to attack you with, right? It might mean that you're a person whose morals are very important to them. It might be that a person who cares deeply about the people around them or their own health. And that's why the thought of you harming yourself or others is so scary to you, right? So usually it's almost the opposite of what the OCD wants to make you believe. And and this is a very, very, very common fusion. Like, am I dangerous? Am I actually aggressive? Am I actually violent without knowing it? Um, do I really mean that? And what I usually discuss with my patients is like, but if you were really violent, if you really meant to hurt someone else, would you be this distressed or anxious about your thoughts? No, you would accept those thoughts as your own because they match your intentions and possibly your actions, right? And that's how you know this is just OCD hitting you in your weakest spot. Okay. Another very commonly asked question: what is exposure and response prevention, in short, ERP? And why is it the gold standard in terms of treatment for OCD? Um, and that's a very important question. Exposure with response prevention, first of all, is considered the gold standard for OCD because there's just a huge body of research that shows that this is the most effective way to reduce symptoms. But we're obviously going to get into, okay, why? So why is it so effective? I just want to mention that this is also the kind of therapeutic strategy that we use here at StopOCD, because it's very important for us to use those approaches and strategies that have the most evidence behind them to be effective and helpful. So what is it and why is it helpful? To understand that on a deeper level, I brought you this little cycle of OCD. Again, if you've ever been to any webinar I've done on any topic, I probably mentioned a cycle at some point in there, because you can wrap almost every psychological problem into a cycle. And the good thing about the cycle is that you can understand where to break the cycle, right? That's why it's so important. And so for OCD, the cycle works like this. Let's imagine some kind of OCD, maybe a person who has religious OCD, and let's say the trigger is that they catch themselves, like let's say it's a man, and let's say they catch themselves looking at a woman, and then they might have the intrusive thought of like, wait, I just looked at this woman. Does it maybe mean that I'm attracted to her? That might be the intrusive thought. Then the interpretation might be, oh my God, if I'm attracted to them, that might mean that I might cheat on my wife or commit adultery, or that I'm attracted to other women in a way that it might damage my relationship. And that interpretation obviously would cause distress for that person, not only because it might imply that they might hurt their wife, but also because adultery is, I think, breaks one of the 10 Commandments. And that distress might be so high that that person might engage in some kind of compulsion or avoidance, for example, not looking at women anymore, or kind of trying to very inflexibly looking only in the eyes or only at in the head area of a woman, just to avoid to possibly kind of look at their body and be attracted to it. So that might be a typical OCD cycle. And now let's look at where we can break the cycle and how ERP can do that. So trigger, no, you cannot avoid triggers in your life. You can't not just, eliminate all women so to not be triggered anymore. Obviously, like that's not a choice. However, and that's something that I clarify a lot at the beginning of therapy when people seek therapy for OCD, they say, let's get rid of the intrusive thoughts. Like, I don't want to have those intrusive thoughts anymore. That is not an option. We cannot break the cycle by eliminating intrusive thoughts. We cannot make them go away. Actually, intrusive thoughts are very, very common. Most people experience them. They might not notice, but if you ask them, most people have intrusive thoughts, just not all of them develop OCD. Right, the first chain in the cycle where we can actually intervene is the interpretation of the thought. We can only relate differently to our thoughts. We cannot make them go away, right? We can question ourselves whether it isn't very normal to sometimes look at another woman and to possibly even be attracted to them. We can question whether this is even something in our control, and reinterpret the intrusive thoughts. So this is something where I can break the cycle. Then I can break the cycle in terms of the distress. I can decide that I want to stay in the distress without reacting, meaning I can also break the cycle at the point of the compulsion or avoidance behavior, because I can decide not to engage in a compulsion and I can decide not to avoid certain topics. So I can decide that I'm still going to continue, to acknowledge the women in my life. And if sometimes it makes me anxious, sometimes I might think that I possibly might be attracted to some of them, I'm going to cope with the distress. Okay, so that's what ERP does basically. It means I'm going to expose myself to the intrusive thought, try to interpret it differently, try to deal with the stress without engaging in a ritual. And it is so effective because it means that you're breaking the cycle, right? It means that you're creating a different path in your brain. Every time you are confronted with the trigger, have the intrusive thought, feel the distress, and then relieve the distress with a ritual, you're creating a path in your brain. Trigger, ritual. The rituals become more and more and more, and they take over your life. That's the problem, right? Once you break the cycle and you kind of say, okay, trigger, distress, and then there's no ritual following, you create a new path in your brain. It's like, okay, there's different ways to cope with those triggers and intrusive thoughts. And that's a very essential learning experience of like, my feared outcome might not come true. I'm strong enough to cope with the distress without engaging in the ritual. It's a very simple idea. It's very hard to do because you're basically meeting your worst fear. But ERP works because we do it gradually, we do it repeatedly, we do it consciously, and with a lot of support from your therapist. Okay. Another question. I have a daughter who has somatized, I never know how to pronounce this. I'm so sorry. Somatization disorder. Her anxiety and history of partial airway obstruction and treatment has led to OCD related to choking and obstruction. How might exposure response work in this case? Also, what meds might be most helpful? So thank you so much. This was a question that was submitted to us. First of all, for those of you who don't know, I want to clarify what somatization disorder is. So it's also known as somatoform disorder. Well, it's so hard to pronounce. And somatic symptom disorder. I think the most commonly used name these days is somatic symptom disorder. And it means that people experience physical symptoms, one or more physical symptoms that are very scary or distressful for the person, that lead them to invest excessive amounts of time, energy, emotion, change their behavior in relation to the symptom. And those symptoms may or may not be related to actual medical conditions. Sometimes there is a medical reason present. Sometimes the reason doesn't completely explain the symptoms, and sometimes there is no explanation for the symptoms. And it sounds like in this question, what happened is that the daughter experienced partial airway obstruction for any kind of reason, was treated for it, but then kind of this whole experience of the obstruction and then the treatment was so stressful for the daughter that she experienced or developed OCD symptoms as as a as a consequence of what happened to her. And this is actually um, a common thing that very stressful events can be kind of lead to an opening for OCD. This basically reminds me of a client that I had, also a girl actually. I think she was 11 or 12, and she had no OCD whatsoever. She was a little bit anxious, in her personality, tended to ruminate over things, but she was in therapy before she actually developed the OCD with me. So I kind of saw how the OCD broke out, and what happened to her is she got some kind of stomach condition, something in her digestive system happened. Up until the end, they weren't really sure what it was. There was a virus probably at some point, but she had cramps and stomach aches for months that really were very, very hard for her to cope with. And up until the end, they certainly, throughout this process, they didn't really know what was going on. And up until the end, they didn't have a 100% explanation. But she had those stomach aches, and she felt really helpless during the process. And what happened is she developed a lot of OCD symptoms that made her feel like she can influence how much tummy aches, how much cramps she was experiencing. Um, but it was OCD because those things weren't actually really affecting her digestive system at all. She just established all kinds of rules that gave her the feeling of control in a situation that was not controllable to her. So like she had to eat always at the full hour. It was about like the different foods she should eat. When actually her doctor would allow her those foods, she would still not eat them because she was afraid they might hurt her. All kinds of rituals around her eating habits that made her feel safe, but eventually led to an outbreak of OCD. Um, yeah, so I'm guessing something related, something similar might have happened here. I don't know exactly what kind of intrusive thoughts or rituals this girl developed. Maybe, possibly, I could imagine intrusive thoughts like, what if my throat closes while I'm eating? Mentally checking, am I swallowing normally? Is everything going down? Can I breathe right? Is my throat tight? Um, what if I choke on this thing that I'm eating right now? And those intrusive thoughts might, be accompanied by compulsions such as being really careful about eating, avoiding certain foods or consistencies, cutting food into really small pieces, chewing for a long time, or asking for reassurance, possibly from parents or from doctors. Okay, so that's a lot of background just because I want everyone to have like some kind of understanding of the situation that's described here. Um, and now I get to the actual question: how might exposure response prevention work in this case? And to be honest, I don't see why it would work any other way than in, regular ERP therapy. Most likely, if that was my patient, I would ask what was her eating behavior before, how what do we know about the eating behavior right now, and about her mental processes while she's eating, about intrusive thoughts, and then step by step try to go back to the original healthy eating behavior. So for example, if right now, let's say that daughter would have a compulsion of chewing everything 50 times, and before that she would chew for a normal amount of time, let's say like 10 seconds, then gradually go back to that behavior. That would be the exposure because it would make her scared that possibly she might choke, and then do that over and over, right? Understand what kind of exposure she has to do to get back to a normal behavior, and then gradually get there through therapy. Obviously, in consultation with a doctor and in an area where all of those behaviors are allowed to her. In addition, I would possibly add something to the ERP in this case, which is called, I think, attention training. It basically means to learn to be mindful about where your focus is. This is also something we see that we do in social anxiety, where oftentimes my focus when I'm in a socially anxious situation is like oh my God, how do other people see me right now? Am I shivering? Am I acting weird? Am I blushing? And then learn to take the focus from being pointed inwards to outwards. Okay, instead of thinking about how do I come across right now, let's focus on the conversation. Let's focus on other people's facial expressions. Even let's focus on the color of everyone's shirt in the group of people that I'm talking to right now. And the same, I could imagine being helpful here. Probably that person when she's eating, she's very focused on the process of eating, on how it feels in her throat. Um, and or in other situations, and then learning to focus the attention outwards to the situation that I'm in, to the people that are around me, to what my senses are picking up in terms of sounds or smells, can be really helpful to just draw this attention to the areas that we're so focused on, because this extra attention can lead to extra sensations. And in terms of medication, I'm always very cautious with advice about medication because I'm not a psychiatrist, but I wouldn't know why, in this case, if you feel like the symptom severity requires medication, why it would be any other medication than in regular OCD cases. Okay, so I hope the person who submitted this question is attending, and I hope this answer was helpful. I think we're going to do maybe one or two more questions. And then I think I've been talking for a while already. Are there biomarkers or tests that can reliably diagnose OCD? So first of all, biomarkers might be a term that not all of you are familiar with. So biomarkers are actually measurable indicators of a biological condition or some kind of illness or symptom. So something that you can measure that points towards a condition. Basic examples of that would be you can measure blood sugar levels to see whether there's an indication of diabetes. You can measure iron levels to see if there's an indication for anemia. So there's much more biomarkers for conditions that are purely medical, biological. But actually, there's a lot of research in the field of psychological conditions, a lot of research, a lot of progress also. But to this point, at least as that I know of, there are no biomarkers for OCD. There's studies about certain genes that might lead to a higher risk of OCD, or even some neural activity patterns, but we don't have something that we can measure biologically at this point that would tell us if someone has OCD or not, or point us towards OCD. So that at this point, the assessment of OCD is through questions, either a questionnaire or an interview, because basically what we're doing is we're not saying, okay, we don't have like a certain virus or one certain source that causes the OCD to break out. It's not like you get the COVID virus and then you get a fever or a cough or whatever, but we know, okay, that's this virus that went into the system that we're trying to measure to then explain those symptoms. With most psychological conditions, it's the opposite. We see all the symptoms, and then we say, oh, well, symptom A, B, and C seem to co-occur in many people at the same time. So let's call this group of symptoms OCD or depression or anxiety and define it based on those symptoms. There might be some underlying cause. We might find out about it later, but at this point, the definition is through just seeing a group of symptoms co-occurring. And what clinical tools that diagnose OCD do, for example, the Y-box, the Yale-Brown obsessive compulsive scale that we use here also at StopOCD, is just simply going through those symptoms and seeing whether one person has enough of a group of symptoms that we would say this is clinical OCD. So it's obviously much less exact than actually finding, a virus or some blood sugar level, but that's the best way we can do it at this point, and it certainly is enough to qualify for treatment. Okay, let's make this the last question for today. Can OCD be treated without medication? So generally, in short, I would say yes. Yes, OCD can be treated without medication. Actually, medication is not even recommended as a standalone treatment. Medication cannot heal OCD. It can reduce anxiety or the stress levels to a level that it becomes easier to live with OCD, or it becomes easier to actually do exposure with response prevention, ERP. So I think my general approach would always be to start with therapy, with ERP first, and then see if you need medication in addition to that. And whether you need medication in addition depends on a number of factors. It might be that the symptoms are very severe. It might be that you don't respond well to ERP, or you're not ready to do ERP because the idea of exposing yourself to your intrusive thoughts is just too scary. And it might be that you have co-occurring problems like depression or anxiety or ADHD or whatever it is that just makes treatment more complicated. And in that case, those cases, I would definitely recommend medication. But yeah, definitely, I think you should try to treat OCD without medication first, and then see if you need the medication in addition. All right. Well, I hope you found those answer is helpful. You now can write down any other questions that might have come up throughout the presentation in the Q&A section. And I see that we already have a few questions, so I'm going to get to those first. Okay, so first of all, an excellent question. Is there a link between OCD and childhood trauma? It's actually been a while since I checked research on that matter, but as childhood trauma is a stressful life event, I definitely would say that there is a high likelihood of a link between OCD and childhood trauma. But I have to be honest with you, childhood trauma is linked to a lot of psychological conditions. So it's not like, okay, someone who went through childhood trauma might develop OCD. They actually have a higher likelihood to develop a lot of different conditions, also depression, anxiety, body focused repetitive behaviors. So it's an adverse life event that makes you a little bit more vulnerable to a set of conditions when not especially when it's not treated correctly. OCD can be a comorbidity for ADHD and autism. Could you comment on this and perhaps address whether OCD is itself an acquired form of neurodivergence? Ooh, it's a difficult one. Okay, wait. OCD can be a comorbidity for ADHD and autism. Absolutely. Can you comment on this? So yes, absolutely. It's very interesting, specifically ADHD and OCD, because you might look at them as kind of the opposites. One is impulsive ADHD and one is compulsive OCD, but there is, I think it was like maybe 11% comorbidity. So actually quite a bit of overlap between the two of them. And research doesn't know to this point how this is even possible, because it basically means, let me take a step back, ADHD and OCD involve the same neural circuit in the brain, but the theory is that OCD leads to an overactivation in this circuit, whereas ADHD is caused by an underactivation, by a hypoactivity, which is very confusing. Like, how can, if one person has ADHD and OCD, how can they experience a hyper and a hypoactivation in the same brain area? Anyways, that's just like some background to that, but like they can co-occur, and definitely also you see higher rates of ADHD and OCD in people who are on the spectrum. So that's my comment on this. And then whether OCD is itself an acquired form of neurodivergence. That is a good question. An acquired form of neurodivergence. I mean, only the question of acquired, right? With ADHD and autism, we kind of assume that a person is born with it. They're born neurodivergent, right? Whereas in OCD, we don't assume a person is usually not born with OCD. They might be born with a certain predisposition to OCD and then develop it later on in life. So I guess, I mean, I don't know if there's an official definition for acquired neurodivergence. I mean, you do see, certain things that are different in the brain of a person with OCD, as I mentioned before, certain structures, certain activity levels. So I don't know if there is an official definition to an acquired form of neurodivergence, but definitely on the neural level, there is a certain amount of difference in the brain of a person who suffers from OCD in comparison to a person who doesn't. And yeah, I'm also wondering why you would ask that, like what it would mean to you if it was an acquired form of neurodivergence or if it wasn't. But definitely there's also differences between ADHD and autism and OCD on the other side, in terms of like some of those conditions are things that you're born with that you can kind of learn to cope with and manage, whereas OCD is something that you can also lead to complete remission. You can get to a complete remission of your OCD symptoms. It doesn't always happen. Usually it's a condition that you cope with for the rest of your life, but in terms of that, it's very different from ADHD and autism. All right. I think we don't have any more questions for today. Um, And in that sense, if any more questions might come up later on, you can always contact our customer support. They can answer your questions, and if they can't, then they will pass those questions on to you, and I will answer them for you. Thank you so much for taking the time and joining. I hope what I talked about today was helpful for you. If there's anything that you're interested that you want me to answer in those Q&A in this Q&A format, then you can write those questions to customer support as well, and we will remember them for our next webinar, and I'm going to answer them. And yeah, I hope you have a nice rest of your day wherever you are. And thank you so much for joining.